This conference will now be recorded.
Great. So project A is, this is the way that I conceive the project. Project A is the bin that contains all the other projects, and it's a little bit of a simplification because project A does have a lot of substance on its own, but none of the participants will be a member of any of the studies that are not part of project A. So that's the easy way to think about it. All participants are part of project A, and some will select some other projects, some will select more than other projects, and some will be only part of Project A, but Project A is integral because it contains all of their urologic history and all of their history components that make them eligible for the study, and all of that information is used in the analysis and all the other projects. So this is, we've looked at this before, but this is the, the protocol. A, we're going to collect 840 people who have urinary symptoms, over 6 sites. That's approximately 140 participants per site, and 120 normal controls. Again, that's around 20 per site. And if you look at the other studies, B, C, D, and E, if you add up the numbers of participants that are needed, they need 294 participants to participate in the that have urinary urgency. So it's going to be pretty easy to get urinary urgency patients to participate in those studies. People can participate in 1 or 2 and we'll make our quota, no problem. However, when you look at the controls, there are 140 participants of normal controls needed to complete B, C, D, and E. And if you look up, you can see that there are 120 normal controls recruited. So it's clear that all normal controls either have to enroll in 1 or more of the other projects for this to work. So that's just something to keep in mind when you're recruiting people. That especially the controls, they're really, although it's not mandatory in the protocol, if we recruit people just for A as a normal control, we're never going to meet our numbers. So that's just something to keep in mind. Each site will keep track of who they enroll for each project, but just something to keep in mind as we're getting started, what our targets and our goals are so that we can complete the whole study. So we're going to have 240 males and females who are all treatment seeking. So these are people that show up to the urology or urogynecology clinic. They all have to have urgency, and they don't need to be new patients. This is in contrast with LURN 1, where all of them were new patients for most of the study, and then we started recruiting return patients. And they don't have to be treatment naive. They can have tried other treatments, they can have not tried anything, they can be undergoing current treatments, and they can have failed other treatments, but basically they're new patients and return patients coming to see one of the providers that is enrolling for LURN. So males, females, new and return visit patients. The control patients, or the asymptomatic controls, 60 men, 60 women, and they really can't have anything going on with their urinary tract. So I'll go over the details in a bit, but basically no lower urinary tract symptoms. They can't have an elevated PVR. They can't be on medications for their bladder or have had any bladder surgery. So a lot of exclusions for those people because we really want people without bladder concerns. So if you had a bladder concern and it got treated with surgery, then you're still not a normal control. So it's really people that have never had major issues with their bladder. And we are going to aim to recruit half of the urgency cohort with incontinence and half without. That is going to present its own challenges because a lot of men don't leak and a lot of women do leak. So that may present some challenges as we recruit over time. But again, at the beginning, we're just going to be recruiting people and filling our bins as we did with LURN 1. But we may get down to a point where we're only recruiting certain characteristics. For example, we may get down to that we can only recruit men with urgency incontinence because that's all that's left to fill. So that's our aim. And the controls, we are going to age match them to our urgency cohort. So we're not going to specifically cherry pick people with specific ages from the urgency cohort. And that's because we have so many participants planned. We figure we're going to get a pretty good age spread, probably a little bit skewed towards the older population. But the controls, we really want to age match them. So we will develop bins to match the controls to the patients we're recruiting. And we're leaving the bins really wide because we don't we don't want to be looking for a 24-year-old female control. We're having, big spreads so that it's not as complicated to recruit. Anyone have any questions at this point in time, or that's pretty clear? I know this is old information, but just wanting to refresh that with everyone.
Yeah. Hello, ma'am. This is Pooja from North Shore. So I was part of LURN 1. So we recruited controls after we had finished recruiting for the cases. That's how they matched it. But since we are going to start with controls immediately, it's okay if they are not age matched, right? We get them as we get them, right?
Right, we'll get them as we get them, but we're going to keep a close eye on recruitment. So if we start recruiting a whole bunch of controls and realize we don't have our cases recruited enough, we may at some point in time say, all right, everyone, hold off recruiting controls. But you're right, we will be recruiting controls from the beginning. But again, keeping an eye on the numbers as we go. We expect it to kind of even out, but we may get to a point in time where we say, all right, stop recruiting female controls, please, or stop recruiting women with urgency incontinence because we've filled that bin. So we will, through the DCC, we'll keep an eye on it, but at first we're just going to recruit, and because recruiting is what's going to be important, and pause if need be. Does that make sense?
Yes, ma'am. Yes, ma'am.
Great, thanks. Great, thanks. Yeah, and please bring up any questions that you have. So our inclusion criteria is a participant has to have urgency or urgency incontinence, and it's the LUTS tool, 1 month recall questionnaire. And it's really only 2 questions of the LUTS tool that they have to answer within a certain, they can't answer never or rarely. They have to answer more than that. So they have to also be bothered. So if you remember, the LETS tool has the question and then it has a bother associated with it. So they have to be somewhat bothered, and they have to have more than rarely or never that symptom. So either of those 2 questions makes them eligible. So you can administer the whole LETS tool and get that information, or you could just administer those 2 questions. Both ways will accomplish the inclusion criteria. Other inclusion criteria, these are pretty obvious ones. They have to be an adult. They have to have a smartphone or have access to a smartphone, because many of the components of the study are going to be through text or through an app. So they need to be able to use a smartphone. And we do realize that this will probably truncate our older population, the much older population, because of this. It's a limitation of this study, and we realize that. But because the information, the way we're collecting it, we're just going to have to live with that limitation. And they have to be able to complete the surveys electronically. So if someone is non-English speaking and does not have the language or cognitive ability to do the surveys, then they're not included. And we also realize that that's a limitation of the study, and we'll include that when we list our results. But that's the way we've designed it. And again, we'll enroll all ages, but match the controls. So exclusion criteria, so people or cases or controls that can't be included in the study are people with a clinical impression of bladder outlet obstruction. So this is a bit vague, and that's why I've highlighted it. So the LURN providers, we had a lengthy discussion about this, and really this is participants who the provider really thinks their problem is obstruction. Their sling is too tight. They have BPH and need a TURP, and believe that that's their primary problem. So that's going to be up to the clinician to decide whether that is something that you're excluding them for. I don't think it's realistic for you to be able to figure that out from the participant. So really, it's if the providers, like, yeah, this person is eligible, they would know not to enroll someone or not to propose someone who has bladder outlet obstruction. But if you have any questions, please just defer to the person who saw the patient, because this is a new exclusion criteria that we did not include in LURN 1 because of reviews from the EAP. The EAP was really adamant that we not include obstructed patients. So people could be a little bit obstructed, but that's not their problem, and they're included, but it's people who that's their primary problem. People who have their primary concern is pelvic pain, so people who have interstitial cystitis, they have chronic orcalgia, chronic pelvic pain, if that's what they're really here to see their provider for, that's not participants that we want in the study. Also, people with significant neurologic disease, so people with spinal cord injury, MS, a history of a stroke with deficits, those people are not going to be included in the study because that's not our population. And also part of the reason that we're not including pelvic pain is because we do have the MAP network that is very similar to LURN, only it focuses on IC and pelvic pain. So that's why we're really avoiding studying those people. And anyone who's had urologic or gynecologic surgery in the last 6 months is not included because that's really going to change our results, and we're not looking for those people. And anyone with a Foley or doing in and out catheterization is not included in the study. And that's also getting back to the people who have bladder outlet obstruction, so it's just reinforcing that. So people who need something to empty their bladder or are obstructed are not included. There's deferral criteria, so that means that they might become eligible shortly, and that would be someone who has a UTI at their visit. They get treated, they get a urinalysis and it's negative, all right, they're in the study. Also, if someone has hematuria, which is a common clinical presentation, they're seen in clinic, they have microhematuria, they get their workup, it's negative, then they can enter into the study. So those are the real 2 deferral criteria. Is that clear to everyone? All right. So this is the long list of exclusion criteria. The previous slide is where I summarized it because it's, but this is really just the, the long version. So if you're looking for the details on who's excluded, this is it. And one that I don't think I mentioned was cancer or current chemotherapy. So someone who has current GU cancer, getting chemotherapy, or if someone who has a mesh or mesh complication, those are also excluded. But this is the detailed list. So if someone has a history and you're concerned, look through the full exclusion criteria. But all of them are pretty easy. But the big broad strokes are pain, cancer, neurologic disease, and people who've had surgery done recently. So for the deferral, the patient can get treated and get a negative urine result. If the repeat dipstick is positive, then they need a urine culture. And if the culture is negative, they're eligible. But if they get another UTI, they're probably not going to be eligible to be recruited because we only have a certain amount of time to recruit that person. So it might be that, because it takes a week, it takes 3 days to get the culture. Probably by that time, they are going to be, past their month of enrollment. So they are probably a lost cause at that point in time. And sexually transmitted infections are the same as UTIs. They can be a deferral. And if someone was pregnant, they can be deferred. So if you were pregnant and you're not pregnant now, we know how long is going to expire until you're 6 months postpartum, and then you could be recruited. And then the urologic surgery in the last 6 months. When enough time expires, then you could be included once 6 months has gone by.
Yep, ma'am, this is Pooja from North Shore. Ma'am, for the deferral criteria, so we do a dipstick for the urine. The dipstick is negative. We don't send it for urine culture, right, ma'am?
Correct.
But if it is positive, then we send it for urine culture, but the patient is not enrolled until the urine culture is clean, right?
Correct.
Okay, thank you.
Correct. And that's all part of clinical care. So if a person has a positive urinalysis, then they need a urine culture, and that's all part of their clinical care. They're never enrolled in the study because they're excluded before they even enter. So thanks for clarifying that. So
This is Alex.
Yes.
I have a question. So patients with prior history of prostate cancer would be excluded.
Correct.
How about patients with prostate cancer on active surveillance?
Excluded.
Okay. Okay. Thank you.
No, and we thought we might as well make it simple. And if, for example, someone who has a history of bladder cancer, excluded. Or someone who's had endometrial cancer, excluded. It's just going to make things too muddy. But that's an excellent point, because there are a lot of guys out there with prostate cancer on surveillance. Our controls have the same inclusion criteria as our cases, so there's no differences there, except they don't have any real symptoms. And we have very specific criteria for what they answer on the LUTS tool. The controls will have to answer the LUTS tool completely, because their symptoms have to be pretty negative all down the board. So you can't just ask them those 2 questions and decide whether they're a control. You'd have to do the whole LUTS tool, because they need to have less than 8 voids per day. They can only have nocturia ×1. They can't have any incontinence. So they would need to answer the full LUTS tool. And the details are in the MOO, but so that's just to explain that, in case you were going to just do the 2 questions for cases. And the controls can't have a diagnosis of overactive bladder, because that's not who we're expecting to be controls. And they can't be on medications for LUTS, so they can't be on Flomax, they can't be on anticholinergics, they can't be on finasteride, they can't be on those medications, because those are all used for LUTS, and it muddies things too much, and then they're not really controls. And if they've had surgery for LUTS, so they've had a sling, they've had a TURP, they've had Botox, then they're not controls. And it's ever is the criteria. So we're really looking for quite clean controls, and they need a post-void residual. It has to be less than 150 cc's. And if they report difficulty emptying their bladder, they're excluded. But that would be captured in the LUTS tool. So this is, kind of duplicate exclusion criteria, but on the LUTS tool, if they answered positively to the question, do you have to push or strain, or you don't empty your bladder, then they'd be excluded for that. This is just reinforcing the point. That makes sense to everyone? I see a comment. The question was, are there any dipstick parameters to be positive, or any amount of nitrate, leukocytes, or small, medium, plus? I would say any amount of nitrates or leukocyte esterase being positive should trigger a urinalysis and urine culture, because a dipstick is not a urinalysis. In all reality, in my clinic, for example, when I get a trace nitrate or a trace leukocyte esterase and you send it to the lab, it's usually negative and the lab is correct. The dipstick is just a screening test. But if there is positivity, it should just simply be sent, if that answers your question, Mary. So this is the schedule. So there's the screening, which happens where they can be assessed for eligibility, and demographics can be done. And between screening and the control visit, 4 weeks can go by. That's the allowable period of time. And this, we are familiar with, what's happening at the baseline control visit. And then there's going to be a 3-month follow-up visit that is probably going to be done in person, because they do need biosamples. There's a 6-month online assessment, which is all done online, a 9-month online assessment, and a 12-month in-person schedule. And we all realize that coronavirus may upend that plan, but for right now, that is what we're anticipating doing, and that's the plan. Pooja sent a text. So if they have non-pelvic cancer and they're not on any therapy, they can be enrolled, and that is correct, Pooja. So say, for example, someone has a squamous cell carcinoma of their forehead, and they have that excised during the study. That doesn't eliminate them from the study. It doesn't prevent them from entering the study. It's, you know, it's an unrelated malignancy. However, let's say someone has leukemia and they're getting chemotherapy for their leukemia. Well, no, that excludes them because they're getting chemotherapy treatment for their malignancy. And so it's kind of, you know, we're talking about pelvic malignancy excludes people forever. Non-pelvic malignancy excludes them if they're getting systemic therapy. And if you have any concerns, you know, you certainly talk to your LURN provider. And, you know, say, for example, someone had rectal cancer, well, that would be considered pelvic malignancy, so that would exclude them as well. So if there's any, you know, queries or concerns, yeah, just talk to your LURN provider. So we've tried to make it as specific as possible, but without listing every single possible cancer. But clearly something extra pelvic, if it's not getting active treatment like chemotherapy, then they're okay.
Excuse me, Anne. This is Mary. I could not unmute for whatever reason, but back to the dipstick parameters. I meant really that to be on follow-up after they had a positive culture and they come back and they have moderate leukocytes or moderate blood. Are they out?
I would send a culture at that
Even
point in
though they
time.
already had one, even though they already had one.
Correct.
Because this, okay, so that answers that. Thank you.
Yeah.
And then the other question is, go ahead.
No, because sometimes someone has a UTI and they are properly treated, but their
Right.
bladder, you know, still has some you know, some unhappiness about it, and it will still have leukocytes occasionally, but again, they don't have a UTI, so they're okay.
Okay. So, and then my next question is, looking at the schedule of events, where do you foresee us consenting? And the reason I'm asking is at that screening visit or the baseline visit, there's 4 weeks between the two. Are you assuming that we're going to consent at that baseline and send them out with their diaries and food, you know, their I&O diary and food diaries? Or are you going to expect that to be given after that first encounter with them?
So I think it all depends on how your site is going to operationalize things. Clearly, we can't have people doing voiding and food diaries for LURN unless they've been consented for the study. But people could get consented at the screening time because there is an online method of consenting patients. So they could get consented at the screening visit and sent, for example, sent their voiding diary, food diary in the mail or electronically. And then when they show up for their baseline visit, they already have them in hand. If they weren't done, they could be given to them at the baseline visit to complete at a later date. And sometimes it depends on how your electronic medical record and your visit system is set up. So I think it'll depend a little bit on how your systems are set up at your hospital or what's going to work best for you. I know at Michigan, I think we intend to try to get some screening done ahead of time and try to get the voiding diaries and food diaries done ahead of time. But again, we're going to try to operationalize that, and it'll all depend on what you think is best for your own site. We did struggle with getting voiding diaries and diaries back in LURN 1 from participants, even though you give them an envelope and stamps. They're not as reliable about returning them. So the idea of having them have them done and then show up to a visit soon thereafter seems to work pretty well. Just 1 second. I'm sorry, someone had opened my office door and was vacuuming outside. All right. Any other questions about the study schedule? We're good? Okay. All right, so again, this is a nice segue to that discussion. You know, so how are you going to capture the LUTS tool at your site? Epic, if that's what your institution is using, the LUTS tool can be incorporated into standard patient surveys in clinic. I know at the University of Michigan, that's what we did for Learn 1 and what we plan on doing for Learn 2. All patients showing up to clinic are going to be given the LETS tool. We're not screening people, we're not enrolling people, we're just going to give them the LETS tool at their clinic visit and using it as part of their clinical visit and using it potentially for study entry. So that's perfectly acceptable because the LETS tool is considered a clinical tool to be used in clinical care. So again, eligible patients can be approached before clinic at a screening visit. They can be approached in clinic when they're there, or even after the clinic visit if the provider thinks that they might be a good participant. And again, all of these have their pluses and minuses. Approaching people before the clinic visit is sometimes tough. People don't answer their phone. People don't want to, people screen their phone calls and might be harder to get a hold of. In clinic, they are a captive audience, but because of just people power limitations might not always be possible. I know at our site, we have providers providing care at 4 different clinical sites, and it's just not always feasible to have a study coordinator come to clinic, especially if you're off site. And after the clinic visit sometimes works well because if I see a patient in clinic, I recognize that they may want to enter the study. I can mention it to them, provide them with a leaflet or a handout, and discuss the concept with them. And with their permission, have my study coordinator call them at a later date. Sometimes that's a more effective way, or at least you get a better hit rate because the participant is already aware that the study exists and that the provider is a member of that. If everyone could mute their phone if they're not speaking, please.
You're welcome. We're on the Learn Project A training. Did you get to confirm your attendance? I can do that for you later if need be. I'll let Arbor know who all at Duke is.
All right, I can't mute everyone, but
she said I had some technical difficulties.
Yasmin, if you could mute yourself, please. Thank you. Does anyone else have any other ideas to share with the group about how they're going to capture the LETS tool at their site? Anything I've not thought of?
This is Alex from St. Louis. So in Learn 1, we approached patients usually by phone after their clinic visit. Mm-hmm. We did phone consent and then asked them those LETS questions for, mm-hmm. to assess for eligibility. So I hope we'll be able to do the same here with Learn 2, because I don't think that LETS tool is standard for all of our physicians. Mm-hmm. Maybe it is for Dr. Lai, but I'm not sure about everybody in the practice that, sees this population.
Sure. And again, I can't, every site has things organized just a little bit differently, and people know their patient population and the geography of their area. I think it depends on how far people travel to come to your clinic and other parameters, and how many providers are involved. So and again, you try it. Sometimes you try it one way and realize that you're not getting enough enrollment, and then you reassess and maybe start multiple approaches. So it all depends on how your enrollment is going, what approach that you use, but all are acceptable. And it just depends on what's going to work for your clinic and clinic process, because we're trying to make this easy for everyone. So whenever we screen a patient for eligibility, we do keep track of who was screened and the reason for them not entering the study. So there was some confusion in Learn 1 because some sites thought every patient chart that they looked at, we had to collect a reason that the person wasn't enrolled, but that's a lot of participants because, for example, I might see 30 people in a day and only 2 of them would be eligible for Learn, and we're not going to put down 28 reasons why people didn't enter the study. So what we did in Learn 1 is we only included people that were actually spoken to. So someone who a study coordinator approached, called, spoke to, and invited them to participate and learn. So someone who A quick chart review was done on, and it was decided that they were not going to be eligible. Those people do not need to be included as screening. We're really including those people that you have reached out to and spoken to, and if they say no thank you, you can ask them why, and that's the end of their documentation. So no need to keep track of every single chart that you look at, because I mean, I know for myself, the reason the person is there is listed in their study or in their clinic visit, and if it says prostate cancer, well, why even open that person's chart? You know they're there for prostate cancer. They're clearly excluded, so you didn't even need to open that chart. So this is trying to cut down on work, but also to keep track of, to make sure that people who decline entry into the study are not different than those people who entered the study. So we will collect just some basic demographic information on those people, and it'll be in the MOO. Does that make sense?
That makes perfect sense, because if you spend all your time listing the OAB patients that you looked at their charts, it's taken away from the ones that you could be enrolling.
Right. Like, who cares?
Right.
If you tried to call someone and they didn't answer, who cares? But if you actually had a conversation with someone and they said no thank you, it's probably worthwhile recording who they are so you don't call them again, and their age and why they don't want to enter the study, and that's enough. So at least it's probably just a good workflow, but at least we're all doing it the same way. So all the sites will be keeping those not enrolled patients the same way.
But we would not be able to share PHI with you on those patients that have declined.
No. But you'd probably keep it at your own site so that you don't call that person again. Yeah, no, you don't share that with us. You share their just demographics and why not. And there's a list of reasons why not in the MOO.
Okay, yeah, that would work.
Yeah. So so the data collected on all patients, this is the summary slide, but at the baseline visit, which is their big visit, they're going to have lots of measures on their bladder, bowel, prolapse symptoms for women. There's the new CASIS. They have adverse childhood experiences recorded. There's some diabetes questionnaires, treatment satisfaction questionnaires. There's a central sensitization questionnaire, depression, anxiety, comorbid medical conditions, a whole list of questionnaires. They're going to be spending quite some time filling out those forms. And we've made some efforts to try to compress them as much as possible. And there is some duplication. There are some surveys that are very similar to other ones, and reassuring people that we realize that there might be different ways of asking the same question, but the thing is that you can't take a survey and break it down and have it still be valid. So people may have questions about why are you asking me these questions more than once, but we can reassure them that this is for research, and we appreciate them just answering all of the questions for us. There's going to be questions on physical activity, lifestyle, coping behaviors. There's going to be an inventory of their medications, supplements, nutraceuticals, and the provider diagnosis and their primary most bothersome symptom and treatment plan. So I believe the DCC is going to take the CASIS short form, or the CASIS, and then represent all of the questions to them that they answered positively and ask them to indicate which one is the most bothersome. In the chart note, there will be a space for the provider to report the patient's most bothersome symptom as well as the treatment plan. And I'll show you the intake form that we've created, but basically there'll be a space for the provider to record their primary and secondary diagnosis, and it's from a short list that'll be included. And I sent that around as 2 Word documents, but they're also templates that can be used. The physical, yes.
1 second. The CASIS or CASIS, I thought was going to be one of the many electronic forms. Is it not?
It is.
Because I thought they were going to do this after their baseline visit.
Yes, so they will do the CASIS at their baseline visit, and electronically in the CASIS, at the end of the CASIS, it'll say, so you have all these symptoms, which one is the most bothersome? And the patient indicates which one's the most bothersome.
Got it. Thank you.
But the provider will also be listing that, but it's not from the CASIS, it'll be from the clinical visit. So the provider's gonna have a space in their clinical visit, like what's their most bothersome symptom, blank, and they have to enter a symptom.
Thank you.
The physical exam at that same baseline visit, they need to have a post-void residual, either ultrasound or cath, depending on what your clinic does. I know my clinic uses an ultrasound. A lot of urogynecology offices do catheterized post-void residual exams. Both are totally fine. There's a space in the template to say how it was collected. Again, there's a urinalysis performed, and if it's negative, there's no culture needed at the baseline visit, which is in line with just standard clinical practice. There's a detailed physical exam, you know, a POPQ, pelvic floor muscle strength. This is all in the template. Women don't need a rectal exam. They needed that in LURN 1, and it's not part of clinical practice, and no one felt that it was useful information, so it was eliminated from this study. In men, they do need a prostate exam, and these exams, you know, either need to be done at the clinic visit or a dedicated research visit if they're not documented. I think it would be everyone's benefit if this was simply done at the clinic visit. So if a participant is a new patient, then it's pretty easy because most clinicians do a pelvic exam on a new patient, but they could also do a pelvic exam on a return visit, but they may need to be reminded to do that because patients do need their physical exam done at that time period, so within the 1 month of enrollment. So it would be way easier if it was done at that time. And again, that's why the EPIC templates were created, to remind providers to do the physical exam. The labs tests, I'll go over them in a little bit, but basically there is serum creatinine, hemoglobin A1C, and lipids. These can be found in the participant's chart. So hemoglobin A1C is good for 3 months, the rest are good for 12 months. And there has been a lab letter that has been created. So if they are drawn during their study visit and the results are abnormal, they'll get a lab letter explaining the results and what to do about the abnormal results. And the labs, as we all know, we're familiar with looking in charts. You know, labs done at the internal lab, so at your home institution, are great. Those are easy to find, but you can also look in external medical records. I know many of us have access to external records through various means. So anywhere you can find their external labs that are within the right time frame is acceptable.
Has there been any talk about the age group for these labs? Only because the 20 to 40-year-olds will probably not have them, so then we'll have to draw on all of those, correct?
Correct.
Okay.
Yeah, no, and you're right. Yeah, most young people will not have any of those labs, or it will be rare that they have them done. And a lot of older people might not have them done every year either. So they may have them, but they're outdated. So again, it will just require a brief chart review to decide if they've been done or not, and them ordered, because they can be collected at the same time as the biomarkers. My next slide, I have how to get a waist circumference in a standardized way. Biomarkers are done at baseline, and we are no longer doing the MOCA-B. This was an amendment, so I've deleted it from this slide since we had decided as a group that it wasn't really worth it. There's demographics and diabetes questions. So I'm going to go to EPIC in my own institution to show you the templates, just to see how they work. So I had Dr. Lai test out my template, and it like 80% works. And the issue is that EPIC is configured a little bit differently at every institution. I have no idea why. No one knows why, but that's life. That's the way EPIC is configured. Like for example, our fake patient at the University of Michigan is Big Bird. And Big Bird is obviously a very important person because he's a break the glass person. I'm going to get out of that one just because that looked a little bit weird. Okay, I'm going to go into test 5. So this is test 5. So I'm going to create a new encounter here. I'm sorry, that's the only way I can do this. Here we go. So, so I labeled, you can label your Epic templates whatever you want. You can see here, I've labeled mine LURN female complete new patient, and there's LURN male complete new patient note. So they're notes that have been created in this. Basically, it's an entire new patient visit. You can use a new patient visit note for a return visit. It's just they're just configured a little bit differently. So this is how the note would appear if I use it. So there's some space for blank stuff, their past history. This is pretty standard. But then the rest of their note will populate with things that are important to learn. Like for example, if you see here, I have a spot where it says their voiding diary is completed, yes or no. Their food diary completed, yes or no. So if they showed up with them, then you'd say they've been completed and scan them in their chart. And then, you know, you don't need to harass the person for them. There would be, again, vital signs, their neurological aids, but then their neurological exam, but also these are 2 LURN questions, whether they use an ambulatory aid or have any neurological deficits. These are just some specifics that are added into the LURN questionnaire or our data entry, like if there's inflammation or atrophy, whether they have a mass or diverticulum, whether they have a caruncle, this is a female patient, whether they have any discharge, if there's any erosion, what their pelvic floor muscle contraction strength is. So it's basically a regular clinic note that anyone would use with the LURN stuff added in so that you don't have to, you know, remember what the extra LURN stuff is. And there's a space for the POP-Q, and then any areas of tenderness, which are part of the LURN questionnaires, their PVR. So I have an automatic PVR pull in. So this test patient had a PVR in 2013, but you can also enter in their PVR manually. It's got their dipstick urine from that visit. It's got their most recent and the date of their lab values, their HDL, LDL, triglycerides, and A1C that have been pulled in from their chart with the dates. So if you see that those are there, then you don't need to search in their chart. It just makes things a little bit easier. Whether they've had urodynamic studies done, and then the assessment and plan, this is the cue to the provider. So the patient's most bothersome symptom is, and there's a blank, and they have to fill that in. The primary diagnosis is this, their secondary diagnosis is this, and we've put a list at the bottom and what their treatment plan is. So I discussed this with Dr. Lai, and his plan was to ask each of the PIs to take this template and to do micro editing that is necessary for their site specifically. Like for example, when Dr. Lai put this in at his institution, the lab work didn't work and the yes/no questions didn't work. So they use a different, see at University of Michigan, yes/no/default 2541 is how you get a yes/no, but that's not how it works at his institution. So it's really strange. And Epic is never going to fix this for us, but at least this is the skeleton that can be modified, and many of these will work with some edits. So he is going to ask each of the PIs or one of the attendings at each site to fix the template that I've created for their specific site. so that it works. Because probably not many of you are doing clinical documentation very often, so being able to create a template is a little bit of a bigger skill, and it often requires, you know, consultation with IT to figure out how to do it. I just make a lot of templates because I've done that for our division for some time, but it usually requires a super user to be able to do that. Does that make sense to everybody? So this is just an example of what you're going to see. I can't tell you exactly what you're going to see because it's going to be a little bit different at each site, but I'm trying really hard to make it easy for the providers to use the right template so that you don't have to hound them for the POPQ results or hound them for the PVR results, that they're included in the note, and it will be obvious to them that they're missing something if they haven't completed it correctly.
Well, I saw some questions about social behavior, like card playing. Those are ones that we could probably take out, unless, is that part of data entry?
Oh,
And
that's part of social history. That's called
yeah,
dot social history. So it just
okay,
loads their social history as part of their medical record. So
okay.
this was not entered as part of the LURN study. Yeah, you're right. We don't need to know if they play cards or not. But it's again, that's what U of M asks people as part of their social history. So it just gets included in, at your site. It might look totally different. Anything in blue here is U of M template. And anything that has no highlighting is stuff that I've entered to make this a LURN note.
Okay, okay. And what do you anticipate the time to get this epic template up and running at each site, approximately? What time
So,
frame should we hope for?
oh, that's an excellent question. It took me 25 minutes, but I
Well,
created them in the first place. So I don't think that it would take someone more than a day to use, because you have to make them and then test them. But it all depends on if you have a super user in your group or not.
okay, okay. Thank you.
Because
So
you
not
can take what I've done and realize these 3 sections don't work and fill them in. So, and I've provided Henry with the templates already. There's one for men and women because I don't include anything about the vagina in the men's, etc. So it shouldn't take them that long to do it. And it's to their advantage. It's going to save a lot of time.
And do we have those yet? Or are they anywhere on the LURN website or?
I sent them to Henry,
Okay,
and I sent them to the DCC to circulate. So that's probably an excellent agenda item for the OBS cohort meeting tomorrow, actually, because the providers will be on that call.
So,
have,
ma'am, oh, sorry, go ahead, go ahead.
okay, sorry, I have a question. If we foresee this physical to be done specifically for study purposes, meaning outside of clinical care, can we use a paper worksheet for this? Is that acceptable?
I can't see why not, because
Okay.
documentation is documentation. So it doesn't have to be within their medical record if you're going to just use it for study purposes.
And and I
So I
guess
think those are all excellent source documents.
we could scan it into media if, let's say, monitoring was to be done remotely or okay, so this could be a paper form. I just for our practice, you know, this exam is very detailed, and I am not sure if other sub-Is in the practice will go through this, you know, extensive physical for a potential participant.
Yeah, and we ran into this issue with LURN 1 that a lot of this information was missing. And I know at our site, our conclusion from that was that we are only going to have LURN physicians, so people who are intimately involved with the project, enrolling patients, because we don't want people who are doing just a quick standard exam enrolling participants to have to redo a physical exam. So at least that's how we're going to start, because we want to enroll patients completely rather than having to redo work. But that might change if we're running into difficulty recruiting, and we may have to do more, but that's what we're planning on doing.
Yeah, so our experience was the opposite. I don't think that we will get enough eligible potential patients from LURN sub-investigators only. So I think we have to try to enroll from the entire practice. And it's difficult to implement this detailed of an exam, for the
It's
entire
actually,
practice.
when you click through it, it's not bad. Like I'll click through this one, normal, no,
Mhm.
no, normal, no, 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 normal, no. So it doesn't
It's
take
prob
that long if you're
it's
used
pro-
to it.
Sure, it's probably not about doing it, it's persuading them to actually
Right,
try.
right. Which why I called mine .learn, so that it's
Mhm.
an automatic one, and trying to, get people in the mindset that they should be using it. Because if the patient ends up not being enrolled, all the information is fine for a regular
Mhm.
clinical visit note.
Got it. Thank you.
So it looks ugly right now, but when you finally click on it all, it's not so bad.
So you asked a great question. So I think you answered half of my question. So what the problem with this COVID pandemic was, I didn't know if we were going to get in patients specifically after consenting. So the provider knew that all this data won't go waste. But I was thinking of also approaching them when they have just finished their clinical visit. So since they have not consented, it's not research, so they can't document all this. So I was thinking of this paper thing that you suggested that would work perfectly.
No, people can document all this information even if they're not a LURN patient, because none of this is outside of clinical practice. So you
Oh,
could use the LURN template for any patient.
oh, okay.
So there's nothing here that's weird.
Okay.
So someone doesn't have a neurological deficit and their abdomen's soft. None of this is a weird, and nowhere does it say LURN, and nowhere does it say research study.
And
So it
ma'am,
all,
it's not extra work for the providers, right? Because
it's a
they
little
are
bit. It's a
like,
little bit.
how much would you say? 10 minutes more?
3.
3 minutes? Okay.
Because it's all yes, no. All the LURN stuff is yes, no, yes, no, yes, no, yes, no. So
Okay.
there's not like extensive amounts of documentation for LURN. It's all the yes, no. So I tried to make it as easy as I could.
Awesome. Thank you.
All right, so I'm going to cancel this note, discard it, so that I don't get labeled as deficient in Janet's chart here, who is not a real person. All right. Waist circumference, just for clarity, if you look up instructions on how to measure a waist circumference, the World Health Organization and the NIH measure it just a little bit differently. The NIH says to measure the waist circumference just above the hip bones. So if anyone's a seamstress, that is not where you measure the waist for measuring for clothes. So just as an aside, the waist that you measure for the World Health Organization is probably your skinniest part, but the NIH measures it just above the hip bones, which is, if you do not have a big belly, is probably at the level of the umbilicus. But again, everyone's abdomen's a little bit different, so you want to measure just the highest point of the iliac crest and keep the tape level. And you want the patient to exhale as you measure, so they don't suck it up or stick out their belly. They should just have exhaled and you measure them then. So just for clarification, and since this is an NIH study, we'll measure it the NIH way, if that makes sense to everyone. So you need to bring a tape measure with you. Providers will not have done this. I've never measured someone's waist in clinic, and I think that's the one area where it's never going to get done. Might as well have the study coordinators do that part. And I will do this again. Okay, so just a discussion on source documents. Again, this is in the MOO, but you're going to get source documents as the patient's medical record, from the patient themselves. And for example, if they saw their PCP and their PCP says creatinine drawn 11-20-20 was 1.2, well, that's considered a source document, and that is okay to use that. Although most of us are not going to peer through their PCP visits and things to find information. However, your clinician may have a stack of paperwork with themselves. So patients come in with a stack of paperwork, and I leaf through it, and I say, oh, patient's creatinine is 1.2 done on 11-20-20. That can be considered source information, and you don't need to redraw their creatinine if it's stated in their medical record at some point in time. Does that make sense?
Yes.
Okay, and there was a question, but it was about the slides, which will be available to everybody. And the voiding diary, we're using the same voiding diary that we used in Learn 1. Some points from the original, iteration of this is that voiding diaries were completed much worse than any of us would have expected. Some real points that we noticed were missing in many patients' diaries were indicating when they went to bed and when they woke up. So that's why I put woke in bed. You gotta encourage, so when you're giving them the information, say, tell us when you woke up and tell us when you went to bed. And this is the example. So it's in the example, but we want to iterate that. We do want 3 consecutive days. So we reiterate that information to them. And we want the volume in and volume out. And they can use a hat, they can use a urinal, they can use a measuring cup, they can use whatever they want to collect their urine and measure it, but they do need to measure it. We also want them to measure bladder sensation, and you probably want to go over that with them because it's it's listed here 0, 1, 2, 3, 4, and you want to measure the leak and the type. So if they leak and what kind of leak it was, and it's in everyone's best interest to give the patient more instruction than less, because if avoiding diaries fill it really nicely, it's so easy to enter. It's like a breeze. Like again, I'm emphasizing the woke in the bed here, but like, look at these diaries. Aren't these lovely? Like this person put bed, 4 ounces of water, bladder sensation 3, 2.0 ounces out, and their handwriting is beautiful. And this is just a dream. Like, oh, 2 beautiful diaries. This is exactly the way it should be, but this is not the way it was for many participants. So we saw a whole lot of stuff like this, where it's just, there's other leak, and the study coordinator contacted the patient, like, what does other mean? And the participant's like, oh no, other means I didn't leak. Oh, okay. So that's completely different than what the instructions say. And this is, they drank nothing. Well, you didn't need to write anything down there. So just, this is medium bad. This is really bad. So, patient put must go, had to go. They didn't put the time. A whole lot of missing things, which make these really hard to interpret. So you're better off giving them better instructions and going over it with them, because if they fill it out better, it just saves so much time in the end. Participants don't need to do it on paper. They can do it electronically if they choose. This is the food diary. I'm sorry, I skipped around a little bit, but the food diary is just a check mark. This is going to be way easier. So you put a check mark if you ate any of those things in the time period. So this is much simpler. They can write as much as they want in the box. It's still just a check mark or no check mark. It's not, we're not keeping track of if they said I ate chocolate and this or that. That's nice. It's still, the instructions are a check mark. So we don't need to interpret it in any way. So these will be pretty easy. But participants can use this app. It's called Vesica. It is only available for Apple products. I just checked the other day. It's still only available on Apple products. It is a free download. If you go to vesicaapp.com, the participant can download it. The instructions are exactly the same. The key phrases, the way that things are stated is exactly the same. It's actually based on the same voiding diary. So that voiding diary, which is validated, is what was used to make this Vesica app. So they can indicate when they went to bed and woke up, how much they drank, their urine output. So they can do it this way. And if they do, they will get, there's very little functionality of this. You can look how you did during the day, and then you can share a PDF. There's only like 3 things you can do. You can record, you can look at your summary, and you can PDF your summary to someone. So that's all that can be done with this Vesica app. So if participants choose to do that instead of on paper, I think this is great, because it does also give them the correct prompts. So it gives you the correct prompts so that you're answering the questions properly. So it won't let you answer the questions with inappropriate versions. So it's asking you for volumes and what it is and how it's measured and that sort of thing. So it's a little bit easier. I encourage everyone, if they have an Apple product available to them, to just click through it, and you'll see how easy it is to use. So in case people want to do that not on paper, the food diary, however, is on paper. That's good for everyone?
Okay, great. Sorry, we have a fire alarm going. I'll be back.
Okay, we're almost done. So the lab testing, I think we've gone over that already. This is just exactly repeated of what I'd written down. I wanted to make sure I didn't forget it. Again, the lab test locations, and again, the template will incorporate only internal labs, but it's still there. The text messaging, we can explain it to participants when they're enrolled that they're going to get a weekly text that's going to say, over the past week, have your urinary symptoms changed, or has your urinary treatment changed? And it's yes to either question, so it's worth going over this with them. If it's yes to one or the other, they answer yes, and they will be given a quick symptom inventory and a medication treatment inventory. If they say no, then nothing else happens. So just encourage people to answer. We only send them one question, so they don't have to answer 2 questions, but it's either or is a yes, then it's a yes. And this should be pretty straightforward. I haven't seen the final output from this, but I believe that it is close to being ready.
Are we able to track whether they complete these on a weekly basis, or if we need to record the medication or treatment?
That's an excellent question. This part of the data entry has been a little bit foggy at the current time, and I'm not sure where they're at. Is someone from the DCC on who can help with that one?
Yeah, let me share my screen.
Great. Do I have to unshare my screen? No.
Nope. Okay. So this is the eye test for a participant in our test site. You'll see here where it has the Project A weekly self-reported treatment and symptom changes. The yellow envelope is how you can send it to them. And then they'll get the link and they will click, oops, sorry. I had it in.
So we're supposed to send it to them every week. I thought it was magically electronically sent by the DCC.
It's about, yeah, so it is going to be sent automatically, but you can also resend it if you need to.
Okay.
Sorry, I got kicked out before I finished my sentence. Okay, I'll go back in here.
So, Miss Melissa, is it sent automatically to the patient, or does the coordinator have to do it?
It's automatically sent
to their email?
To either, well, so the email is their, the PROs, and then the SMS, it goes to their phone in a message. And then what they'll do is they'll click what the message they're going to get is this one. It just says, please click on the provided link to answer the questions regarding your urinary tract symptoms. And then when they click on that link, it'll actually take them directly to this document. It has all the PROs in it, and the CASIS is the very first one. And when they click on the link in the text messaging, it'll take them directly here, and where it asks is, have they had bladder change, symptom changed, or they started. And if they put no, everything else gets grayed out and they're done. If they say yes, then they'll have a couple more questions, and then they'll also have the treatment changes in the LURN SI10. Okay. And that is what it will look like. Any questions?
Yeah, Ms. Melissa, this is Pooja. I just want to know for my data governance, are we putting their email ID and phone number both?
Yeah, so we have a notifications preferences where you'll get their phone number for text messaging as well as their time zone, and then about when they would like to have them sent to them, and then the email for their notifications as well. So that's the information you will gather so that they can get these automatically and you won't have to worry about it sending it to them. And we'll go through this more on the link training tomorrow. Oh, go ahead.
Great, thank you so much. That was the part that I was foggy on too, so thank you.
Okay, yeah. Let me find you here again.
All right.
And I will make you presenter again.
I'm almost done actually, so we're
okay,
pretty close.
Great.
All right, so this is more information that I'm going to have to emphasize with the providers, less so with this group. So, the question is, what is the primary and secondary diagnosis for the patient? We've reviewed this with the providers more than once. It's implemented in the EPIC template. And again, it's not what's coded or what's billed for, because a lot of the coding is based on historical diagnoses that don't even exist. So we're really looking for, the provider to actually state what is their primary diagnosis. And these are a list, the same list that is included in that template of possible reasons that someone is there. The list is different for men and women. Like, for example, I'm not going to include, BPH for women and not include vaginal diagnoses for men. But this is the list, and they list a primary. They can have just one. That's okay. Sometimes they have a primary and a secondary, but we're not, if someone puts a third or fourth diagnosis, well, ignore those. It's primary and secondary. That's all we're including. And again, there are other reasons that someone might be in clinic. For example, a participant might have microhematuria. That's really why they're there. They got their workup for microhematuria and it's negative, and they're like, oh yeah, and by the way, I have terrible urgency. So urgency is really their secondary diagnosis, and they were there for something else, but and it's not going to be collected. You don't have to write it down. The answer is other, but it's not, their primary is just other. And again, there are exclusions. So if someone put down that this person's primary diagnosis is neurogenic bladder, then you can remind them, actually they're excluded, so forget it. So these are just things that shouldn't be included in their diagnoses because it's not what they're there for. If they wanted to include urodynamic diagnoses, if the patient has had a urodynamic study done in the past 2 years, this is in the template, and these are possible diagnoses that will be there. It'll probably be a real minority of participants that actually have urodynamic diagnoses. So you may need to reach out to the providers if they've had them done to give that answer, but so it's included in the template as well. But no one's expecting anyone to look at the urodynamics and interpret it and find the diagnosis in the end. I would defer to providers because reading urodynamics is pretty complicated. I would just ask them to say what the diagnoses were. So there's the follow-up at 3 and 12 months. Again, this is taken right from the, I really just copied and pasted this. If a participant does go to have surgery, however, that person time 0 will start after their surgery. So their 3-month follow-up might be a little bit later. This is outlined clearly in the MOO, but it's just those particular people who at the first visit are booked for surgery end up deferring their 3-month visit. So it'll change based on that. And the follow-up visits, we looked at the table and they have many of the same data points collected, but there's no physical exam again. So that's the easy thing. Those follow-up visits don't need to be with a provider. They can be with a study coordinator only, because there'll be biomarkers and surveys and things like that. Any questions about the follow-up visits? I think those were pretty easy. They're very similar to what they were in Learn 1. Right, great. I know there was a list of surgeries in the MOO that participants could have or have not had. This is a list of surgeries that are available. We would like to try to use this list, particularly if that's what the patient had. And sometimes there are more than one ways of saying something. For example, there's different ways of doing a TURP. You know, there's a microwave, there's a laser treatment, there's the UroLift, there's a needle ablation. If the patient's not sure and you're not sure, you can always just say TURP unknown kind, but we'd rather try to use the categories that we have so that we don't have to recategorize them later. And sometimes it's hard to tell what the person had done, and sometimes they don't even know, particularly prolapse repairs. Patients might call them all bladder lifts. Everything's a bladder lift, and you don't know if that's a sling, you don't know if that's a prolapse repair. It might require a look back at their chart to figure out what they've had done before. But again, we do our best to try to categorize them properly. Any questions about this? The remote visits are really going to be a contact point, a short assessment of interval treatments, and these are really going to be quite short, so not as detailed or involved, and hopefully these will be pretty easy. They're very similar to Learn 1, so nothing much more beyond that, and no samples are obtained at these visits, so these are pretty easy to do remotely. And I think with the way healthcare is going, I think people are very much more apt to do medical consultations and visits over the phone right now. So I think these will be pretty easy to do. All right, just the one thing about visit windows that is important, and you know, the baseline visit is up to 4 weeks after the initial visit. So the first time the patient's seen in the clinic, so we have that window to get their baseline visit done. And many of the part B, C, D, E are also within that window. And the questionnaires and biospecimens have to be collected within 2 weeks of each other. It's best if they're on the same day, but within 2 weeks is acceptable. They're all going to be dated, so that's easy. And again, the 3-month follow-up visit, we know 3 months is a vague term. It can occur 1 month to 4.5 months after the initial visit or surgery. And again, there's a range of dates for the 6-month, 9-month, and 12-month visit. So if people aren't contacted at exactly that time, we have some date ranges that thankfully don't overlap. So you know when those visits are occurring. And again, this is all in the MOO. And that is all I got.
Whoops. This is Mary. I had a question for Melissa. Is there a reason the protocol, the updated version, and MOO are not on the website? Or if they are there, can you tell me where? I see version 1.5, 1.3, 1.1. Is it because not everybody has IRB approval, or?
No, it's because I got the documents last night.
Oh,
so that's why
okay.
I sent them out this morning. And I'm actually printing labels for another study, so I just have not had a chance to do it yet.
Oh, that's fine. I just thought
I will get stuff uploaded. Today, it won't be today.
No problem.
Yeah.
I thought maybe there's a site that I'm just not finding.
Yep,
okay.
No. I will get it on there though. Yep.
Okay, and we all know that things are going to come up during the study, things that we couldn't plan for or didn't anticipate. And I mean, we all know how research goes, so I think we'll continue to be flexible. I know some questions came up about enrollment. Again, we're going to try to enroll as best we can with our local restrictions and limitations, and do the best we can when that's possible. But again, it's going to be a project in motion as we go. This is the plan as it stands today, and we'll do our best to follow it, but we'll be flexible.
Absolutely.
Thank you, ma'am. Ma'am, the thing is, will you, the PIs or somebody follow up with our PIs to make sure that the Epic Learn Mail patient note is ready when we are ready to go? And if we can get a copy of the note, so if we have to print it out and make it into a paper format.
I sent them to the DCC already, and again, we'll discuss that on the OBS call tomorrow. So where the PI should be on that call. But again, yes, we will get those circulated so that people have access to them. I'll send Henry a follow-up after our talk today, and maybe he will want to send those out immediately to the PI so that they can get working on it.
Thank you.
And everything will get posted to the study website. So I'm going to say everything will get posted by Monday, the 7th. If I can get it to it sooner, I would definitely will.
All right, awesome. Thanks, everyone. Hopefully the rest of the trainings go well. And I said, you have my contact information. I'm happy to answer questions if you think of something as time goes on. We'll be emphasizing the template to all the sites because it's just going to make life so much easier.
Thank you.
Thank you, Anne.
Great. Thanks, everyone.